you everybody for joining us. Apologies for the very last minute change in time and date. There were some issues with Zoom, and we wanted to make sure we were able to make the whole presentation and give you all the information necessary. So I will do a quick intro, and then Dr. Canseco and his PA Ryan will take over. So Dr. Canseco is one of the spine surgeons here at Rothman Orthopedics. He sees patients in Bordentown, New Jersey, Hamilton, New Jersey, and Pennington, New Jersey. He is a fellowship-trained spine surgeon, and he specializes in the surgical management of degenerative spine conditions and traumatic spine injuries, as well as the treatment of complex pathologies of the lumbar, thoracic, and cervical spine. Along with him, we have Ryan Urban, who works as his PA. He's been working as a spine surgery PA for about 3 years, and he and Dr. Canseco make a wonderful team that anybody should trust. It's who I would send my parents to if they needed a spine surgeon. So without further ado, one last thing. If you have any questions, the Q&A is open. At the end, we'll go through and ask the questions. Try to keep your questions general, not specific to an injury that you may have or an issue that you may have. We'll keep them nice and general. And if you have anything more specific, I'll put some information in the chat so you can reach out to me directly. Okay, I'll be quiet now. Go ahead.
Ryan, can you still see my screen?
Yes, sir.
Perfect. Hi, everyone. Again, my name's Dr. Jose Canseco. I'm one of the spine surgeons at the Rothman Institute. My practice is mainly in, South Jersey. We do see patients in Bordentown, Hamilton, and Pennington, and then we do most of our surgeries at Capitol Health and Robert Wood in Hamilton, but we also do surgeries at Jefferson in Philadelphia. And today I wanted to talk about a topic that we get a lot of patients to come treated, and it's people have a lot of questions, particularly people over 65, and it's something that it's important to know because a majority of the time you do not need surgery. And so this is a misconception. People think I have a fracture, I need surgery, but a majority of the time you don't. And I wanted to teach that because many are going to experience these, and you can treat it conservative with therapy and avoid a visit to the spine surgeon and be told that we can't do much for you. So it's a good topic to understand. Now there are certain cases where you do need surgery, and we'll talk about that. So again, a little overview. Compression fractures are common. About 50% of people over 80 will experience a compression fracture, and about 25% of people over 70. In general, they happen in people with weak bone, osteoporotic disease, and in low energy trauma. You guys trip and fall from steps. Fall over the edge of a car when getting out, and it's a compression fracture because the top end plate and the bottom end plate tend to crush each other, and then you have a deformity of the vertebral body, and it's very common in the thoracolumbar region, the midline around the chest and the lower lumbar spine, and they tend to be very painful. So who is at risk? Again, it's advanced age when the people that tend to get osteoporosis, more common in females because of menopausal osteoporosis, and in people that have poor nutrition, low BMI, smokers, or a history of prior fractures. Those are the people that tend to have this. It's also very common in those people that use chronic steroids, for instance, people with rheumatoid arthritis or autoimmune diseases, or that have a poor diet in calcium and vitamin D. That's why most people, when they go to the PCP, as they hit 65 or older, they get supplementation with calcium, vitamin D, and this is the reason that we try to push that to try to prevent this, because we have modifiable risk factors like low vitamin D and calcium, and non-modifiables like age and gender. So this is important to understand. How do we diagnose it? A lot of the times the patients come into the emergency room because they have significant pain after a fall, and then they end up getting X-rays, CT scans, and hopefully for our benefit, an MRI. And people present with a sudden back pain and a curvature in their spine or loss of height. Sometimes low energy trauma, or in some patients it happens when you're picking up something heavy at home like a TV or a heavy box. A majority of patients, a large majority, have a normal exam. There's no weakness in the legs, there's no numbness and tingling, and they just have tenderness in the area of the spine. So when you come to the emergency room after they do your neurologic examination, they end up deciding, well, let's do imaging. And the majority of the time it's just an X-ray. You can see on the image right there from one of the research papers I found that you can see a little wedge compression fracture right by the neck, the white arrow, and that's what you'd see. Now, that doesn't tell you how new or how old this is. Many patients do have prior fractures where they had back pain, they didn't notice they had it, and they just wait. And so the key is getting a CT and an MRI to notice chronicity. The gold standard is an MRI where you can see recent edema or swelling in the bone that tells you the acuity of the disease. Many of them happen without any necessary trauma or just by accident, and it tends to be significantly painful. It takes a long time to heal. One of the things that people complain is when you have a fracture, you start developing a hump, or what we call kyphosis. You start leaning forward and then you lose height. And then getting compression of your spinal canal and your spinal cord is very rare. Only when you have significant trauma where the bone pushes out into your spinal cord and leads to compression would you develop more neurologic symptoms like weakness, numbness, tingling, or sciatica type of pain. Now that said, once you're in the emergency room, thorough evaluation is necessary because many times this can happen from other conditions other than osteoporosis. In rare events, it could be metastatic cancer that presents as a pathologic fracture, and that should be considered. And it could be if the fracture is higher in the thoracic spine, then you can have a little more difficulty with a neurologic issue. Or if there's any atypical issues or failure to thrive, we have to find out the reason whether there's malnourishment to make sure that we address those as well. Sometimes it can happen in young patients that tends to be higher energy, but that's a different type of fracture that we don't cover in this topic. Um, so once you have that diagnosis in the emergency room, a lot of the times they call the spine team and they evaluate. They look at the imaging and they're like, "Well, it's a compression fracture. It's a recent onset. The normal examination." We tell the ER, have them take pain medication, Tylenol. Sometimes tramadol is necessary, and then they can give you a brace. And then the key is to work up the reason for it. And if it's osteoporosis, you need to get a DEXA scan. Many of you have had a DEXA scan in the past, and that just tells you how mineralized your bone is. If you lost the bone mineral density, how weak your bone is. And then depending on the level and the score you get, if you have less than negative 2.5, then you have osteoporosis. Between negative 2.5 and 1, then you have osteopenia, and then higher you have normal bone mineral density. What you want is you want to make sure that you start getting treated with supplementation if you have osteopenia, and if you have osteoporosis, then you need medication to treat that bone mineral density. And bone mineral density peaks differently in men and women. In men, it tends to peak between 19 and 33 years old, and females between 33 and 40 years old. So after that, everybody loses some bone mineral density unless you keep an active lifestyle and weight training as part of your routine. So it's important to make sure that you get your DEXA scan every 2 years to ensure that this is not happening to you, to avoid one of these injuries. Now, how do we start the treatment? Like I said, pain medication and rest. We do want you to start mobilizing right away. Once we look at the imaging and we determine that you do not have an instability in the spine, then physical therapy and mobilization is important. We don't want you to get any blood clots. We don't want you to get stiff. We put you on the brace for improved posture and sometimes pain control, but it's not absolutely necessary. There are some countries in Europe that then don't give braces to the people that have this condition. But in the US, we do, because we find that it tends to help with pain control and posture. And we use that for anywhere between 6 to 12 weeks. Some patients, the pain goes away right away and they start doing well with physical therapy. So we get rid of it so you increase your range of motion. Other patients take a little longer to feel better. And the key is that once we make the diagnosis and we start treatment, we want to make sure that you get that treated. If you have osteoporosis, you need to see primary care doctor, endocrinologist, or rheumatologist so that they determine how bad your disease is and then how to start supplementing. Calcium, vitamin D is going to be part of that treatment, but then you can do first line treatments if it's not significant disease where they can do oral medications. You can do also hormonal therapy like estrogens in younger postmenopausal women. And then we have new recent medications that target the new pathways for bone mineral density enhancement, and these are medications that we tend to give patients that have more advanced disease to increase the density faster. So we have this one Evenity, which is a monoclonal antibody that increases the formation and decreases resorption. You get it every month for about 12 months. Forteo is another one many of you in the area may have heard. This is one of the medicines that they gave Carson Wentz when he had a fracture because it helped heal faster, and you get a daily for about 1 to 2 years. It reduces the chances of subsequent fractures. And another one is Prolia. Many of you are in that, and that also it's an injection every 6 months. This is very good for compliance patients that don't want to take it regularly. It helps you increase your bone mineral density, it's important to see these as options. That's why you need to go to the right providers. the brief overview is first line, you start with bisphosphonates. If that medication over time is not helping, then you switch to the more significant ones unless you have severe disease. Um, Now we go to the surgical option. So some patients do fail medical management. They say you go 3 to 6 months and you still have significant pain. The height of your disc is not improving, or even more acutely at the beginning of your disease, if your pain is severe. One of the options is getting a kyphoplasty, which is cement augmentation of the vertebral body. We're going to see a picture of it next. And the second one is if we determine that by imaging that the fracture is a little more severe than just a wedge fracture, and there is some suggestion of an instability where your spine is not stable, or you start having neurologic deficits, weakness, pain in your legs, then surgery may be necessary to try to decompress those nerves. Or over time, if over the period of 6 months and you're doing well, but you start developing a hunchback that's significant and prevents you from walking efficiently, then that's another people that need a decompression and stabilization to restore that alignment or decompress the spine or restore stability. Now, kyphoplasty is one of the things that we try in patients that fail medical management or have severe pain. In this case, what we do is pain management or a physiatrist in our practice do it. They put a little needle and inject and then use a balloon to expand the space. And then they inject a cement into the vertebral body to restore that height. That cement gets really hot and effectively kills the nerve in the vertebral body, so the pain tends to get better. But we just really observe it for severe cases more than 6 weeks to months, and it's something that is not for everybody because there has been some trials that show that there's limited benefit, but it's an option. And then spinal fusion, you can see in the pictures on the right side in this case, when you have significant compression fracture and over time it gets worse, then patients tend to get kyphotic. They tend to start falling forward, and we can do something like that surgery on the right side in the D image, where in surgery, we restore the alignment. We put screws with a cement augmentation to try to stabilize the level above and below, and we put rods to hold it in place. And then in many cases, we put a bone graft in the past in the posterior aspect of the spine to create a fusion to stabilize the spine. And that's one of the options if you have progressive deformity, or more acutely if you have an instability. And it's again rarely needed. It's mostly for major instability or nerve compression. If you have neurologic deficits or ligamentous disruption, that's another one. And there's many ways to treat this. In some places, in some centers, they do. In Germany, for example, everybody gets surgery when they have a compression fracture. They do what we call short segment fusion. They go one level above and below. In some other centers, when there's more concern for instability, they tend to go 2 to 3 levels above and below to stabilize the spine. But as you understand, when you fuse, there's no going back. Once you fuse the spine, then you lose some of that range of motion. You increase the stresses locally that can put you at risk of developing additional disease above and below. So we try to save it for the necessary reasons. Now, in certain cases, when the collapse of the bone is severe, or when the bone has something we call necrosis, and resorbs, then we may have to replace it with a cage. And that's when you go into more involved the front anterior from the front or from the side. We reach the level where the bone has collapsed. We take it out and we replace it with a cage, much more involved process in order to restore the alignment. And then we supplement it with screws in the back. And that's again in very rare cases. For a majority of the time, most patients get better with time, pain medication, physical therapy, and bracing. And then and that's the main line of practice. So when you experience one, remember you don't necessarily have to see a spine surgeon. Not everybody needs surgery. As long as you get treated by the appropriate provider, they diagnose you correctly, and you get the medical management that you need at the beginning, treat your osteoporosis, you can prevent this from getting worse in a majority of the cases. Now, in order to prevent this, exercise is important. You want to have strong bones, and the more you use your bones, weightlifting, cardiovascular activity, you can increase that density, calcium, vitamin D. And then once you do have osteoporosis, fall prevention, there's some certain regimens of physical therapy that we can prescribe, where you train with the therapist on how to prevent falls or how to catch yourself in a way that prevents significant injury. Now, once you have a compression fracture, things that we want to prevent is kyphosis, immobility, and pulmonary compromise. So if you start losing your deformity, if you start flexing your spine, if you start getting kyphosed, you can decrease the space your lungs have to breathe. You can also have immobility and develop blood clots. So we want to prevent that to try to avoid those complications. And now I'm gonna pass it on over to Ryan. I want him to speak a little bit about what types of therapy activities we do. once you come to us or you come to a provider and they say you need therapy, these are the exercises that are going to help you try to get better.
All right. So hi everyone. I'm Ryan. I'm Dr. Canseco's physician assistant. So Dr. Canseco went over a couple of things like the causes of compression fractures, like traumas, falls, or you can of course get like non-traumatic compression fractures if you have pretty bad osteoporosis. Now, what I want to go over is a few exercises that you can do at home to try to one, prevent compression fractures, and two, if you already have one, it can strengthen the body and try to prevent more of that like kyphosis that Dr. Canseco was talking about, that curvature of the spine formation, and it can help prevent any further compression fractures. So topics that we like to focus on in physical therapy: exercises to improve bone density. So if you already have osteoporosis, you're going to want to be on those medications to help treat it. But we also want to do a few exercises to start building up that bone. Also, a lot of compression fractures happen because of falls. So we do a lot of leg strengthening and balance training to try to prevent that. And then if you do have a compression fracture, we do some activities to try to prevent that kyphotic curve from forming. Next slide, please. All right, so first we'll start with a couple exercises that you can do at home to improve bone density. So first two ones, real simple exercises, some lunges and squats. Now, if you're one of those people that have difficulties with balance, I want you to be very careful doing this, especially the lunges, because I don't want you falling over and then getting a compression fracture that way. So I have a couple activities down the line that we can do for those. But really, doing the lunges, you want to keep your body nice and straight, keep the spine nice and aligned. And then what you're going to do is you're going to bend the one knee at a time and try to get that forward knee to a 90-degree angle. And that's going to start activating the muscles around the bones. And that's what's really going to cause some strengthening. So you want to do maybe about 15 of these at a time, and then do 3 sets of those. And, I always recommend doing these kind of activities every day. I know that's hard sometimes because of life. But I say minimum at least 4 times a week. Okay. And then next slide, please. Yep. Next slide, please. Yep. Perfect. All right. So some more activities to improve bone density. So on the far left picture you see here, you can do these things called step ups. So you can either use like one of those soft blocks that you can get at, like Dick's Sporting Goods, or Walmart, to use that. Or, if you have some low-lying steps, you can definitely use that as well. So for that activity, it's going to be more of that strengthening of the bone. So you're going to want to take steps up and then up and down, forward, but then also you're going to want to do it from the side as well. So more of like a lateral step. And again, you really want to do like 15 steps at a time, give yourself a little break, and try to do that 3 sessions. Another activity that's really good for building bone density is heel raises. So pretty much you're just going to keep going up and down on your tippy toes to try to build up those muscles. But if you're one of those people that have difficulties with balance, you can do the same exact activity, but you can do it in a seated position to prevent any kind of risks of falls. Okay. And next slide, please. All right. And then again, this is a really big one. So balance training, you can do these things called foam pad marches. So you're going to want to go grab one of those really light foam pads, again, at your local like Dick's Sporting Goods or Walmart. Or, I mean, if you just have like a soft rug at home, you can also do these activities on those. And really, it's kind of like your army man march. You just want to keep raising your knees high, usually to hip level, and then keep your arms moving. And what that's going to do is it's going to give you balance improvement on each leg at a time. And now if you have difficulties with balance already, you can also do these things called sit to stand exercises. So you want to start in your chair, cross your arms, and then you're going to lean forward a little bit and then stand up. And then you're really just going to keep doing up and down, again, usually about 15 times in 3 sessions. And that's going to help your legs get used to stabilizing your body to prevent any falls. Next slide, please. All right. And then if you have really bad balance, I just wanted to throw in some more exercises that you can do to start strengthening the body. in more in like a laying position. Like you can do these in bed or do these on a soft rug. The first one is a side lying hip exercise. As you can see in the picture, lay down on your side, you bend the bottom knee, and then basically you're just going to keep raising that one leg up and down, and trying to keep it as straight as possible. And all of these activities, you want to do about 15 reps of it 3 times, and that's going to start building up those the hip muscles to try to stabilize the body. Also, you can do the straight leg raise, top right picture here, laying flat on the back, bending the one knee, and then just keep raising the one straight leg up and down. And then the bottom right, you can do these things called bridges. This is a little more difficult. So, you know, if you have the capability of doing this, this is good. But if you're a little nervous on this one, then you can always skip it. But usually what you want to do is you want to lay down flat on your back with your knees bent to about 90 degrees, arms kind of pushing into the earth on your side. And then you're going to want to just thrust like your abdomen and pelvis forward. And that's going to activate the muscles in your abdomen. So, you know, when you're talking about the spine, you really want a key aspect is strengthening all the muscles around it. So you really want to strengthen the muscles directly along the spine. You want to strengthen the abdomen, and you want to strengthen the legs. So all these activities are really trying to stabilize that, because if you have stable, strong muscles, it's going to you're going to have a stable spine. Okay, next slide. All right, and then this is just another picture of that kyphotic deformity that Dr. Canseco was talking about. So the picture to the left, that's what your normal spine, that's what you normally want it to look like. And then to the right, you can see that there's a compression fracture right in the middle, and it's kind of forming that that hunchback or that kyphotic curve. Now, in the next few exercises, this is more of once you already have a compression fracture, we want to try to reduce the risk of forming this curve. Or if you already have this curve, it can try to improve it slightly with some activity. So next slide. All right, so a lot of these is going to be, it's a lot of posture exercise. So if you already have, like, if you have like TheraBands, like resistant bands, you can do these external rotations where basically you want to start 90 degrees, and then you're just going to pull out, keeping your elbows tucked. Okay. Now the picture to the right is if you don't have those, don't have the TheraBands. You can kind of do it by yourself, but if you're going to do it that way, you're going to want to extend all the way to kind of like you're trying to get the shoulder blades to kiss, and you're going to want to just keep doing that to kind of strengthen those muscles in your upper back and your neck to try to correct your posture. And then again, another activity you can do, TheraBand rows. Really, you can see there, you wrap it around your feet. Be careful with this one. Make sure you're, you know, I would recommend having shoes on with this because you don't want it slipping. But you want to keep a nice posture, nice straight back, and then you're going to be doing just pulling it straight back, like if you're doing like if you're rowing a canoe. You know, and that's really going to help strengthen those muscles and keep your posture upright. All right, next slide. And then some other ones that you can do. These are also, these are better if you have, you know, difficulties with balance. You can do these wall push-ups, you know, basically very simple. It's like you're standing straight up, put your arms resting against the wall, and then you want to just keep going forward, back and forth. You know, I say about 15 times, but, you know, you want to do that about 3 reps each time. That's going to build those shoulder and back muscles. And then also you can do these seated extensions. So if you're sitting in your chair, you know, I like this one because you can, you know, you can do it throughout the day. Like even if you're at work, if you do have a desk job, you can just actively be doing this during breaks. You know, put your arms behind your head, and then, you know, it's kind of like you're trying to crack your back. You're just bending back to try to strengthen and stretch those muscles. And then all these activities, they're really the idea is to strengthen those muscles so your posture is kept upright instead of falling forward. Okay. Next slide. All right. So this is my favorite slide. This is very important. So home exercise program is something that I recommend people do every day for their entire life. You know, you're supposed to do it 2 to 3 times a day. That's hard. If you can do it at least once a day, that would be the best. Now, why is this important? So even off the topic of osteoporosis and compression fractures, I believe everyone should be doing a home exercise program. It's really how we slow down arthritis in the spine. So, if you develop bad arthritis in your hip or bad arthritis in your knee, we can go in, we can replace that joint with an artificial one, and we call it a day. But, we can't replace the joints in your spine. So if you start to get that bad arthritis, we really just have to deal with that with things like medication management or injections, because we don't really have a surgery that we can offer to alleviate like arthritic pain. All right. So, if you're looking for the home exercise program, you can just go to Google and type in AAOS, spine conditioning program, and that stands for American Academy of Orthopedic Surgeons spine conditioning program. It's about 13 different exercises, top to bottom, and it also includes activities for the abdomen and legs, because you want a firm base, so you have a firm spine. Next one.
All right. So again, that was a very thorough evaluation and summary of how we do physical therapy. And like Ryan said, like I said, the mainstay of treatment, almost every patient that we get consulted for in the hospital or that comes to the office with a compression fracture, the first line of treatment is pain medication and and physical therapy. We work very closely with our own therapists at Rothman Physical Therapy. We work closely with IV therapy, with Novica therapy, professional therapy, with many of the in the area. But if you have one that you work with, I'd be happy to give you my prescription that you can bring to your therapist so they can follow the regimented program that we have that can help you get you on your way. And it's going to take time. Most of you you have to understand that you got to be patient. It's very painful because you have to heal a fracture in the setting of most of the time osteoporosis, where your bone is not solid enough and is not quote unquote healthy enough to heal itself quick. And so it takes a long time to heal. Part of that healing process is getting diagnosed or treated for osteoporosis so that you can improve your bone mineral density and speed of the recovery. But it's going to take time. So I've had patients that get better in 2, 3, 4 weeks, 5 weeks. I have patients that take 6, 7, 8 months to get better or longer. And that's when, having a group of professionals, not only orthopedic surgeons, but physiatrists, physician assistants, physical therapists, rheumatologists, endocrinologists, even primary care doctors, we want to be talking to each other together to make sure that we get your specific case into a better way of getting treated. And so again, it's going to take time to heal. So be patient. It can be frustrating. A lot of the times we'll see you every 2 months, every 3 months, and you continue to have symptoms. And eventually it should get better with the right treatment. Early diagnosis is important. One of the highest predictors of another compression fracture is a previous compression fracture. So if you had one and you didn't get treated, you're at a very high risk of having another one. And so the bracing can help, not necessarily because it heals the fracture, but it improves your posture. It reminds you have an injury, and you try to avoid activities that can lead to pain. Again, physical therapy is important. With physical therapy, you want fall prevention. We also want to see you over time. And even if we finish treating you over the period of 6 months, say, Ryan and I bring you back about 6 months later, a year later, to monitor your posture, to make sure that you're not falling into what Ryan showed you, kyphosis, because we don't want you guys being like the hunchback and not being able to look forward, because then that increases your risk of fall. So that's another important thing to monitor you over time. And again, as you can see, the key of the treatment is osteoporosis. If you treat the source of the problem, then you reduce your chances of having problem later. And again, many patients come to our office with a mistaken belief that they were told they need surgery for a compression fracture. Do not panic. Most people don't need spine surgery for this, and we can treat it medically and conservatively. Now, I'm answering as questions as they come. To some of you, I already have the answer. Please feel free to call us and come see us, either Ryan or myself, for an appointment. And we're happy to see you in any of our offices at any time, as needed. And again, remember, the first line of treatment is osteoporosis diagnosis. So make sure if you see a rheumatologist and endocrinologist, your primary care can do this. Get that DEXA scan so you know where you stand and how you can help start it and prevent getting one of these injuries. And that's really it. I'm happy to answer a few more questions. And if you have any additional topics you want to talk about, definitely let us know, and we'll be happy to cover them. I wanted to keep this to 30 minutes because I know everybody has dinner right now.
Thank you so much. Do you want me to go through and read some of the questions?
Yes, please. You can
Sure.
read them and I answer them.
Yep.
I'm going to keep answering some of these. Okay.
Great. What is the recommended daily dose of vitamin D supplement in milligrams? They sometimes tell you take it with vitamin K, but can you take it alone?
So yeah, you can take it alone. I take vitamin D alone. I had low vitamin D last year, and that's what I do. But I was trying to look for a resource. Sherelle, I had a so if you go to the American Academy of Orthopedic Surgeons, there's a whole article, and I'm gonna try to see if I can post the link on how much vitamin D you need to take because it varies by age and by condition. So it's hard to tell you this is how much you need. But usually there's guidelines, and depending on your diagnosis and and the value that you have, there's different doses that you need. So I don't want to make a generic recommendation. Some people need 400 units, some 800 units. So let me post that article so you can see it and then use it as a resource to talk to your primary care doctor, rheumatologist, and endocrinologist about what specifically you need. Let me see if I can go there.
And if you can't
Uh,
find it, I have to send a follow-up email with the recording. So you can always just share
Perfect.
it with me in the next couple days and I'll send it out next week.
Perfect. That's a better idea because otherwise there's no way of me getting out of this one. Okay, perfect.
Okay.
Let me stop.
And
Yeah.
can we get a single list of exercises being recommended?
So I think we can do that. I think Ryan can put those in a Word document and send it to you, Kristen, and we can share
Mhm.
them.
Okay. Sorry, I'm just taking some notes here myself. You recommended braces and then something about possible blood clots. Did I hear you correctly?
No, so what that means is that if you have a compression fracture and you're not engaged in PT, you become immobile where you're sitting on the couch because you're in pain. Not moving can put you at increased risk of having blood clots in your legs, and so that's why we mean about being active and maintaining movement and activity because we don't want any blood pooling in your legs and getting some blood clots that can lead to trouble. So that's the way that you can get that. And then braces, like I said, is not for everybody in the US we use it regularly. In Europe they don't use them, and so it's one of those things that we believe helps control your pain and your posture. So that's an important thing to do.
Are any of these medications not recommended for heart patients?
It depends what type of heart disease you'd have. That you would have to talk to your cardiologist because there's certain osteoporotic medications that may have some side effects for the cardiac side effects. So that's more disease specific. I recommend you talk to your cardiologist.
Do you know about osteoboost.com?
No, I haven't explored that website.
Okay. I've been diagnosed with PSP. I'm trying to improve.
Yeah, no, I've been chatting with Ron,
Oh,
so
okay.
I think he's been
Okay.
trying to do work, so that's good. We're happy to see you, Ron. If you want to if you have any more specific questions.
Why would you wait on a fracture to potentially get sclerotic and make kyphoplasty more difficult down the road? Also, what are the risks of adjacent level fractures with conservative treatment versus post kyphoplasty adjacent level fractures?
So that's a good question. It's a little more complex than we can answer in this setting, but so it's not that you wait for kyphoplasty. There's many studies that have shown that kyphoplasties don't work. So there's a school of thought of some surgeons that use them, some others don't, and so that's why you depends on the specific provider. You see that they make a decision. You use it in the setting of restoring height. A lot of the times you can restore height. And so it's more nuanced than that saying that you wait for sclerosis. And many patients don't heal their compression fracture, so you don't develop sclerosis in that level. When the other part of the question is, what are the risks of adjacent level fractures with conservative treatment? So anybody that has osteoporosis is at risk of developing an adjacent segment compression fracture, not only adjacent, anywhere else. And so the risk is there. If you already had one, there's a chance you have another one. So the key is to have a to have to treat your osteoporosis. And yes, it's a good point. If you get cemented kyphoplasty in one of the vertebral bodies, you increase the stress. There is a slightly higher risk of developing fractures on other levels, but it's not necessarily related to the procedure. It's just part of the osteoporotic disease.
What are your thoughts on more modern or up-to-date forms of mechanical vertebral augmentation procedures such as Kiva, spine jack, etc.?
Good question. They're not as streamlined, they're more surgical, but yeah, those are options we use in the operating room for certain for certain conditions. We've used it for tumor augmentation on corpectomies. So you know, that's again depending on the specific predator you see, they have different options that they can treat, and those are other options you can try. They're just more specific in the type of treatment that you need it for.
I have a couple people here asking for the slides. I know we don't typically send them out, but I just wanted to confirm that with you.
I mean, I think so. I think we can. What we do is we share the video, right? So they can just go on
Yeah,
YouTube and
you're
share the
right. You're
video.
right. Well, I
That's
didn't
the
think
way they
about
can
that.
see the slide. Yeah. So you just go on YouTube and you can see the video, and then that's the best way.
That's the best way. Yep. Where in the spine do compression fractures normally occur? Does good posture help prevent these fractures?
They happen, and they can happen anywhere. Most commonly in the thoracolumbar spine, and the only way to prevent it is with exercise and good bone health. You know, if you are over 65 or you have a medical condition that makes you prone of osteoporosis, get to your primary care doctor, endocrinologist, rheumatologist, get a DEXA scan, know where you stand, and initiate medical management, because that's how you can prevent it if possible.
Do you recommend PT for a back injury without an initial X-ray?
It's hard to say. Some providers do it. We always want to get an X-ray to make sure that we rule out a fracture and make sure that we give you the right type of physical therapy.
Are there risks of doing extension exercises for thoracic spine with compression fractures?
Where is that? I want to read it again because I want to make sure I
Yep, that's
understand it correctly.
638. That one came in. Amy Necht.
Let me see, 638. Are there risks of doing extension exercises for the thoracic spine with compression? I mean, technically, yeah, depends on what exercises you're doing. The key here is finding stability. If you happen to have a compression fracture that has an instability, doing extension flexion exercises can lead to some problems. So that's why getting a diagnosis, getting an MRI that tells you whether or not you have an unstable spine is important to make sure that we guide you to the right to the proper type of treatment.
I have a couple questions here about who orders a brace. Would that come from you or is that coming from PT?
No, it could be a provider. Like I said, most of the time we don't treat the compression fractures initially. They've done in the ED, or you can get it done at your primary care office. But we've ordered them for patients in the office. A lot of times the emergency room orders it after they diagnose you with it. The therapist can definitely order them. Most of the time they want a doctor to be involved in the process. But any provider, primary care doctors can order them. It doesn't have to be me or a PT. There's many providers that can do it.
What about compression fractures in the hip?
That's a different topic. It's not necessarily a compression fracture. It's an osteoporotic fracture. It's like it's a hip fracture. Those can be problematic too, and you know, I'd recommend you talk to a traumatologist for those. But yeah, they're associated with osteoporosis, and they in general they need to be treated promptly with surgical intervention with a nail or hip replacement. So that's important to talk to the right providers.
What about kettlebell workouts? Are they okay to do?
Yeah, after you get diagnosed, I always recommend before you start doing exercises in the setting of a compression fracture, get diagnosed, go to a initial 6-week period of physical therapy with a therapist that develops a program for you. And once you're cleared from a pain perspective, then you can start going to a trainer and do more kettlebell training. It's definitely good as long as you do the right way, because you can think about it. If you use too much weight as you're swinging the kettlebell, you can get significantly injured. So it's important to start slow before pushing yourself.
What clinical trials do you know that advocate for more conservative treatment versus kyphoplasty? Will not getting a kypho lead to more invasive surgery down the road?
Not necessarily, and there's no clinical trials. There's different types of treatments. I'm part of the AO Spine Knowledge Forum Trauma. It's a big group of surgeons around the world that try to develop guidelines, and we just did a significant study that showed that in the right setting, having surgery early is important, but not everybody needs surgery. So it doesn't have to do with the kyphoplasty or no kyphoplasty. It depends on the pattern and the injury that you have. So that's why we recommend you see somebody to get the imaging so that you're told you can be guided as to which is the best treatment to start with.
Where can I find an OMM in the US?
OMM, I'm not sure what
I'm
that
not
is.
sure
I
what that
mean,
is. I thought you would know.
what question is this?
637, Rosanna Quash.
Let me see. 637. I'm not sure what it stands for.
I'm
OMM.
not sure.
If you can spell it out, then I'll let you know if I know what I can help you with.
Okay. There's a question about patient advocates with patients that have several arthritic issues from a car accident. I don't know who that would be. Do you know of anybody?
Yeah, no, I mean, sometimes the social worker can help at the hospital. If you have a social worker that was involved in your case, then definitely that they can help. But unfortunately, we were focusing on for osteoporosis. Usually, when you have a car accident, it's a little more involved. So it's definitely a hospital social worker that has resources for that.
Are the risks of doing extension exercises for thoracic spine
We
with
we
compression
already did that
fractures?
one.
Oh, we
We
did that
already
one.
did that
Oh,
one.
I
Yeah.
forgot to hit done. Sorry about that. Um, I heard soda can damage bones. That's an interesting
Yeah, I mean,
question.
it's poor nutrition. So yes, it has more to do with nutrition. If you only drink Diet Coke or regular Coke, sodas, then you're not getting the nutrition you need to support your bones. So that's the way it's associated. There's other more biochemical pathways, but it's not necessarily related to this.
It's a good one. Can you improve your bone density or bone loss?
Yes, with exercise, vitamin D, calcium supplements, and also with the osteoporotic medication. So if any of you have a doubts about that, most important thing is get your DEXA scan, get your type of your bone condition, and then either go to a rheumatologist, endocrinologist, primary care to get that managed.
Piggyback back off of your last comment. How do you decide between an endo and a rheumatologist?
It's specifically for osteoporosis, it can be either or. Now, if you have more hormonal issues, endocrinologists tend to be better. If you have more autoimmune issues, rheumatologists tend to be better. But specifically for osteoporosis, either one is fine.
Have a 25% L3 compression fracture. Is that area more at risk for further fractures?
Not necessarily. 25% is, about a quarter of the way down. Now, if it stopped, it doesn't necessarily mean it's a problem. Now the key is to know why you had it, and if it's osteoporosis, getting treated. So I'd recommend that you get diagnosed and then improve your bone mineral density to try to avoid subsequent fractures.
Here's a good one, probably something you hear a lot in your clinic. I find it difficult to get a doctor to write for a CT scan or MRI. They might write for an X-ray, but will say an MRI or CT isn't necessary. How does one convince them?
You know, a lot of the times the problem is insurance. A lot of the times, if you come to our office and you want an MRI right away, I'm happy to write it, but most insurances are going to say that you need 6 weeks of physical therapy or forms of treatment before they even approve it. I'm happy to write it. I just can't guarantee you that your insurance is going to approve it. Now, if you have a compression fracture on X-ray, and we have X-ray in our office at Rothman that diagnoses it right away, then I can write for an MRI, which I prefer over CT at the beginning, because it's warranted to know the acuity of it. So in most of those cases, it doesn't get rejected. But I don't think it's that that the doctors are being difficult. Is that the doctor knows that if we order it, the insurance is not going to approve it. And certain insurances have a policy that if they deny a request at the beginning, you have to wait 6 to 12 weeks before you can re-request it. So your doctor may not want to have to wait 3 months. They rather not write it now, start you on therapy, and then have the ability to order it a little bit later rather than tell you it was denied. Now we need to wait 3 months before we request it again.
Do you work with patients with osteogenesis imperfecta?
So most of those that treat is diagnosed when you're a child. So I trained at Penn and I did my residency at CHOP. So if you have that, CHOP has a specific center for that. So as a recommendation, we don't tend to see it as an adult spine providers. I've seen it in the office, but I do refer them to CHOP because they have the geneticists and the specific type of providers that take care of that.
Is 80 years old too old to start osteo medication with severe osteo when you're hypersensitive to medications?
Well, it depends what type of allergies you have, but no, not necessary. Not necessarily. I've had patients that have a first compression fracture at 87, and we started them on treatment, and they're doing well.
Can a second round of biophosphonates be appropriate for individuals who had an initial regimen of biophosphates in their early postmenopausal years?
So that's a good question. I would so in certain settings it's okay, but I would recommend you talk to an endocrinologist or rheumatologist. Those are the trained people that know the nuances of treatment with with osteoporotic medications and can have a much better answer. So my recommendation, I'm happy to refer you to someone if you need.
And we'll do just a couple more here. Which area of the body is a most reliable indicator of osteoporosis?
It's hard to have an answer to that because when we do a DEXA scan, in some centers they do the hip, the lumbar spine, the forearm. In other ones, they do both forearms and both femurs. It depends on where you get it done. What it is mostly an average of all your areas. And if there's one area that has osteoporosis, then in general you get diagnosed with it because you may have osteopenia or less in the others. As long as you have one that has the issue, then they diagnose you with it. So there's no one better area. They're just the most common ones to get injured are the hip and the spine.
How do you know how much weight you can safely lift? None of my doctors have any comments on this.
It's because it's very patient specific. It's hard to say because it's not that we can quantify when your bone is going to break if you're lifting. So that's why having a bone mineral density test, DEXA scan, and starter treatment is important to try to increase that. And then going to a therapist that can start you on a gradual strengthening program is better than going, full duty on a workout program without supervision.
Is the pain associated with compression fractures originating solely from the nerves inside the compromised bone, or will it also come from the transversing nerve roots in adjacent segments due to loss of structural integrity?
So that's a great question. So a lot of the back pain comes from the bone, the basic vertebral nerve that's inside the bone. That's the one that gets compressed and irritated. However, if you do have some retropulsion or collapse and you're compressing the nerve roots that come out, then you'd also have pain there, but that'll be more radicular pain, more pain down the leg. So it's different type of pain, but they both can be affected. Most commonly, if you don't have the leg pain, it is the nerves within the vertebral body that hurt.
And we'll have this be the last one. And then if anybody else has any additional questions, please send them to me and I'll shoot them over to Ryan and Dr. Canseco. Where and how can I get quality of bone checked as opposed to just the bone density?
I mean, that's it. I think so. Endocrinologists and rheumatologists do bone health. There are clinics that are the bone health clinics that do more testing, like blood work. DEXA is one of the most important ones. Another one is a CT scan where they measure Hounsfield units, and then there's newer modalities like ultrasound. So if you go to one of those centers where they do bone health, primarily endocrinologists and rheumatologists, then you can get a more thorough assessment that includes everything else.
And then just I see this one twice, and then this will be the last one. Any recommendations on specific calcium supplements?
No, I mean, over the counter, you can find many. I don't prescribe it. I usually tell people to grab it over the counter. Your primary care doctor definitely they have their preferences, but no, there's no brand that I can think of. When I needed one, I just went to GNC and I looked at the back of the bottle. But no, I don't have any specific one that I recommend.
Okay. All right. So I think we'll stop there. It's getting pretty close to 7 here. So thank you. Thank you everybody for joining us. And thank you, Dr. Canseco and Ryan, for a super informative presentation. I feel like I learned a lot watching this. Like I said, this presentation was recorded. I have to wait for it to get uploaded to YouTube and it'll be emailed out probably by next Monday or so. And if you have any questions, I think everybody has multiple emails from me, so you can reach out to me directly via email. And if you would like to schedule an appointment, I can help you with that.
Thank you, everybody. Hope this was informative that we quash some of those fears you have about a compression fracture, and then that at least we steered you in the right direction to try to get an early workup to prevent this from happening to you.
Oh, this was so great. Thank you, guys. Have a great night.
Take care.
Have a good night, everybody.